Welcome back. I'm Army Pikett, and this is Blood Gas of the Week, case number 7. This is a very friendly 3-year-old female spayed pit bull presented with a 2-day history of vomiting. She's eaten multiple toys and pieces of toys in the past, but she's always been able to poop them out. Today, she can't keep any food down, and there are pieces of toy stuffing in the vomitus. On exam, she's quiet. She's got moderate abdominal pain in the left caudal abdomen. Thoracic auscultation is normal, and she's got normal femoral pulses. Cardiovascularly, she seems fairly stable, and ultimately she ends up being diagnosed with gastric and small bowel foreign material on abdominal imaging. Her blood work comes back prior to surgery, and this is what we've got. So, step number 1 in the blood gas analysis is to determine if this is an arterial or a venous sample. This one's venous, so we get to go straight on to the acid-base analysis. First, we're going to assess the pH. It's high, so we have an alkalemia. Alkalemia can be caused by either a low PCO2 or a high bicarbonate. This patient's CO2 is high, so that's not the cause. And her bicarbonate's also high, which would cause alkalemia. So her primary process is a metabolic alkalosis. We would expect to see the CO2 rise to compensate, and that is what we see. So, let's look at this from the tic-tac-toe method. Here we see the pH is high, which gives us an alkalemia. The CO2 is high, which means we have a respiratory acidosis, and the bicarbonate is high, which means there's a metabolic alkalosis. Now we see which process lines up with the pH. In this case, it's the bicarbonate, so the metabolic component is causing the primary disturbance. Our patient has a metabolic alkalosis. The PCO2 is moving in the opposite direction, a respiratory acidosis, so this looks like compensation. So, our initial assessment is a metabolic alkalosis with respiratory compensation. However, as we all know, looks can be deceiving. So, we'll go ahead and check using the calculations to see if we have more than one acid-base problem. When the primary problem is a metabolic alkalosis, the formula says for every 1 point increase in the bicarbonate above normal, the PCO2 should increase by 0.7 points. So let's take a look at our patient. First, we're going to see how much the bicarb has changed from normal. The normal bicarb is about 20, so we'll take a normal bicarb of 20 and subtract that from our patient's bicarb of 29. That gives us 9. So for every 1 point change in the bicarbonate, the CO2 should change by 0.7 points. We multiply 9 times 0.7, which gives us 6.3, and we're going to round that to an even 6. So we think the CO2 should go up by about 6 points in response to the normal bicarbonate. The normal PCO2 is about 40, so we add 6 to 40, and we get 46. This means we would expect the CO2 to be about 46 if the change in the CO2 is just compensation for the metabolic alkalosis. But we know that there's actually a range for normal CO2 and bicarbonate in our patients. Not everybody's normal bicarb is 20. Not everyone's normal CO2 is exactly 40. So we need to use a range, and the general rule is we're going to use a range of plus or minus 4 on either side of the calculated value. So our calculated value is 46. 46 minus 4 is 42. 46 plus 4 is 50. So the patient's measured CO2 happens to fall into the 40 to 52 range. We're going to say the change in CO2 is probably all due to compensation. Our patient's CO2 is 53. It's a little outside the range. So we probably have more than one process going on here. In this patient's case, maybe she's really dehydrated, or maybe she is in occult shock. Either of these could cause a mild metabolic acidosis to be present in addition to the more severe metabolic alkalosis, and those would shift the bicarbonate around some. The other possibility, when you see this, would be a primary respiratory disturbance on top of the metabolic disturbance. But she was reported to be bright and interactive and breathing normally, so this seems less likely. Ultimately, we should start treating her for any dehydration or hypovolemia from her GI losses, remove her foreign body, and recheck in a little while to make sure things are normalizing. So, our final acid-base diagnosis is a mixed disturbance characterized by alkalemia, a metabolic alkalosis, and respiratory acidosis. Enjoy the rest of the week. Until next time, keep the rubber on the road and the blood inside.